Welcome to Brian Health Podcast. I'm Melanie Cole, and today we are talking about weight loss surgery. Joining me is Dr. Chris Seip. He's a general surgeon with Brian Health. Dr. Seip, thank you so much for being with us today as we get into this topic. And wow, there's so many tools in your toolbox today. It's really an exciting time in your field. But I'd like you to start by kind of giving us a working definition of obesity and the economic burden. I mean, we're really seeing an epidemic in this country with our children and with our adults. Speak a little bit about how you define it so that then we can talk about what we're doing about it.
You bet, Melanie. Thanks. And yeah, it's a pleasure to be here. Obesity, when we start talking about that, and specifically, I'm a surgeon. So when we start talking about patients who might be candidates for, say, weight loss surgery because of their obesity, we in general are talking about patients who probably weigh around 100 pounds over their ideal body weight. And so that means when we calculate what we talk about in medicine, the BMI is going to be around a BMI of 40. So for the average person, if an average person is 70 kilograms or 150 pounds or so, that's going to be weighing around 250 pounds. So it's a fair amount of weight for people to try to lose. Unfortunately, when you look at our statistics in society, we know that it varies a little bit by region, by state in the country, but in general, the population is at least 40% overweight, and that would be, say, BMIs between 25 and 35. And then the rates of morbid obesity, so like I was just suggesting, 100 pounds over ideal weight, those numbers approach 15 to 20% in some states. So it's a really common problem, one that impacts so many aspects of life. It's an expensive problem from a medical perspective to take care of illnesses that are directly a result of the weight. And so it really does impact almost every aspect of life.
Well, I'm glad that you mentioned there are comorbid conditions as a result of obesity. Just speak a little bit about those because I think that they have a bearing on why it's so important to consult your provider because they cause so many complications that then lead on down the line.
Yeah, they really do. And they compound each other. So some of the more common associated comorbidities, which are just illnesses that are directly related to obesity, would be type 2 diabetes, which is an insulin resistant condition. And with that condition, there's numerous other systems that are involved as a consequence, which include the kidneys, heart disease, risk of stroke goes up. And so hypertension included in that group. So there's several things that as a result of maybe having type 2 diabetes, the other systems are going to be impacted as well. And it's not just the diabetes and or cardiovascular disease that's at risk. One of the more common conditions is obstructive sleep apnea. And that condition also, it's most commonly somebody whose symptoms are snoring at nighttime, and that directly impacts other systems as well. So it's a pulmonary condition, but it impacts the heart pretty substantially. And patients who suffer with obstructive sleep apnea, they really feel miserable. Their energy levels are completely down. Because of that, their stress level or cortisol levels are really high. And as a result of that, their metabolism is completely messed up. And so it's a vicious cycle. All of these things spiral out of control. Trying to get the weight off, oftentimes medically, is really difficult, especially when you're looking at the amount of weight we're talking about. And so that's kind of where my specialty comes into play. Weight loss surgery has statistically been well documented over decades to really provide substantial weight loss.
Well, as I said at the beginning, this is such an exciting time. There are so many options. And before we discuss those, what had been done previously, Dr. Seip, in terms of weight loss? Were we just kind of throwing up our hands and telling people to exercise and eat less? When we think of these historical weight loss efforts, which people found very, very difficult. I mean, there are weight loss programs out there. And so I'd like you to just speak briefly about some of the things that we used to do and why we're looking at all of these different interventions now. And then you can tell us about what's available now.
Yeah, you bet. So for decades, it's primarily been just like you suggested, you need to exercise and you need to eat less. And unfortunately, when you look at studies, the success rates with those two measures or lifestyle modification alone are really discouraging. 5% of excess weight on average can be lost over 12 months with those two efforts alone for the average person. And that's not enough to impact any of the illnesses that we're talking about. And so, again, that was decades. Surgery has been around for a long time. It's been around since maybe the mid 1970s, and that's evolved in what it would have originally looked like to what it looks like now. Some of the more durable procedures, like a gastric bypass, they've been around for 30 years or so, maybe just a bit longer. Those have also evolved as to how that's done now. And so now, as opposed to telling people you just have to change what you eat and exercise more, we do have some options surgically. There are also some newer medications coming down the pipeline that help with weight loss. So, all of those things, when you look at any given patient, number one, they will need to change their lifestyle. That's part of the deal. Even with a surgery, even with some of the newer medications, it still requires those lifestyle modifications, but we really can achieve much greater results with weight loss. We're just talking about weight loss, but honestly, we call it metabolic surgery. And so not only do the patients lose weight, but really we affect their metabolism. And that's probably the greatest when you look at long term stuff. Changing their metabolism is the key. And some of the newer meds, they also work by changing metabolism. So they provide weight loss, but really they dramatically change the system.
We're going to touch on some of those meds later on, but I love for you to tell us the options that are available because some of them are tried and true and some have changed a bit over the years.
Yeah, so gastric bypass, like I mentioned, would have been done around the early 90s to mid 90s when it started, and that was done through an open, regular big incision. That has persisted and it's been a gold standard for weight loss for many years. It works by restricting how much a person can take in, but it also bypasses a portion of the intestine, so there's malabsorption of nutrients. And so calories that are taken in are not absorbed, even though what you take in is restricted. And so that, for a lot of patients, has been the gold standard. It provides 70 to 80% of excess weight loss potential. The alternatives surgically, when you look at them, another one is a duodenal switch, which is somewhat like a gastric bypass. There's a restrictive component to that, as well as a malabsorptive bypass segment. And so that similarly will provide great weight loss, 70 to 80% of excess weight. Both of those, because of rerouting the intestine and bypassing a portion of absorption, they do have long term nutritional consequences. And so those are patients that have to be followed lifelong for many of the nutritional potential deficiencies. Really, one of the other mainstays of surgery now is a sleeve gastrectomy, and that's where we just take out 75 to 80% of the stomach and leave behind a long gastric tube, which does a couple of things. It is restrictive as to how much a person can take in, but it's also metabolic. The part of the stomach that's taken out with that surgery really contributes to much of a person's hunger, desire for food, the problems with insulin sensitivities. So when we take that part of the stomach out, it does change immediately those hormonal things. And that's a consequence of the surgery that's immediate and long standing. So, the sleeve gastrectomy for a lot of patients, when it's considered also one of the lower risk procedures, is for many people the right decision. Those are the three mainstays. The gastric band that has been around decades now, it's been probably 25, maybe just longer years. It's fallen out of favor to some degree because much of the time, when you looked at average weight loss with a band in place, which was a mechanical device put at the top of the stomach to restrict how much a person could take in, it had many potential failures from a mechanical perspective. It also had long-term complications of erosion and or malpositioning requiring additional surgeries. Most patients didn't achieve over 50% of their excess weight. And so as a surgical society, we really have felt like if you can't get to 50% of excess weight off, it's really not something that should be considered as a long-standing option for a patient. So it's kind of fallen out of favor anymore. We take more bands out than are put in.
Yeah, that's really interesting. That was a great explanation of the types that you offer. So there are parameters. This isn't something someone can just walk in and say, okay, I'd like a sleeve gastrectomy. Can you please tell us the parameters for bariatric surgery as you look at your patients, what they have to go through for sleeve gastrectomy or bypass, and what you tell them every single day about these parameters, why they're so important?
So, in general, when we look at people who we talk about as candidates for these surgeries, again, it's back to the BMI as one of the first things we look at. And a person with a BMI that's 40 or over, because that puts them at around 100 pounds on average over their ideal body weight, those are people that immediately we think, yeah, even without other associated illnesses, they would be a candidate to talk about surgery. And in that, if a patient doesn't have those illnesses at this time, it just means not at this time. They very well down the road are going to. And so it's a preventative thing for patients without illnesses. But when you look at patients who do have those comorbidities in place, especially type 2 diabetes and cardiovascular disease or sleep apnea, we lower that criteria down to a BMI of 35. And even for some studies now, it's well documented that BMI is down even to 30 because of this metabolism component of the surgeries. If we offer that to a patient with type 2 diabetes and a BMI of 30, it cures their diabetes. It'll cure patients with higher BMI also, but because of that metabolic change, these surgeries in general would be offered for specifically type 2 diabetics down to a BMI of 30. If those other comorbidities aren't present, then we usually stick pretty strictly to that 40 BMI and above. And certainly those patients stand to benefit terrifically by losing substantial weight.
Dr. Seip, what do you want them to do if you've discussed this with them and it's a shared decision making in advance of surgery? Should they be trying to lose weight? Should they be exercising? Are they getting counseling? Because I know that's a part of it as well.
We'll do a either monthly or every other month seminar where any potential patient who's considering this comes in to have a thorough understanding. It's presented usually by the surgeon to discuss, like, this is the reason that we're talking about this. Are you a candidate? And we really to educate them about what's involved with the preoperative process, what goes on in the OR, and what the postoperative process looks like. And preoperatively, then we get full medical evaluation. We get also psychological evaluation. We have most patients seen by pulmonology and cardiology to assess what their current illnesses are and what their future risk might look like. And then really try to pull that all together for the individual to see what's their potential benefit to go through this, and make it sure that they have a good understanding of what the risk is, but also on the other side of it, what their success might look like. And we do encourage them, even from the very beginning, to make those lifestyle modifications. We used to have criteria to say patients who were, say, super morbidly obese, where we'd be talking about BMIs over 60, that they had to lose a set amount of weight coming into the surgery before we could consider them. What you find if you've done this long enough is that's a really difficult thing. There's a reason those patients have gotten to the point they are, and to require that preoperatively for most of them isn't going to be successful. So a lot of times they'll be down some as they come into the process, but they don't have the benefit of the surgery in place yet. So we encourage the lifestyle modification, knowing that their success preoperatively will be difficult, and postoperatively, at least they'll have those changes in place to really catapult themselves into success.
And as we say, this is a tool. And for people that think that this is an easy way out, it's not. And it is a lifestyle complete change, right?
Yeah, you're exactly right. I mean, we will hear oftentimes a family member or friend who has said that they're going the easy route by doing this, and it's honestly not. It's just the person taking responsibility. And it's simply a tool, like you said, that really in studies shows it's going to help them be more successful than they could ever be without this tool. But it's simply a tool because it still requires all of the changes we just talked about to be successful.
Well, I agree. And I think that people that endeavor to do bariatric surgery are brave and taking charge of their own health. And that's really what's so important, that we all have to be our own best health advocate. Now, as we think about what's going on today, Dr. Sipe, we see medical weight loss and we see medications that are out there like Ozempic and things. Speak about the results for bariatric as you've seen in your career versus these kinds of medications that are out there now. When you're talking to your patients every day, what do you tell them?
You bet. And even most recent studies, just in the last several months, when we look head to head from a surgical weight loss perspective versus even the newer medications, hands down, surgery beats them every study done. So when you talk about medical weight loss, even with the new GLP-1 medications, In general, we're talking about patients being able at most to lose 25% of their excess weight. And I just mentioned that we don't consider it right to put bands in people anymore because we couldn't achieve 50% of excess weight loss in patients. So when we're talking about surgical weight loss, we're talking 50 to 70 and 80% of excess weight off. And when you compare that to medical weight loss, it's not even in the same ballpark. So again, 25% versus 70 to 80% is a big difference. And the impact on their life is similarly a big difference. The changes too with these medications, there are consequences and side effects. And many times the patient has to be on them lifelong. And so that's the challenge. The thing that we don't quite understand yet in medicine is what that's really going to look like. These surgeries, like we're talking about, if we can get a patient through them safely and into that postoperative lifestyle, they can be successful for the remainder of their life at keeping the weight off. And so we really consider them durable, permanent solutions as opposed to medication, which is not proven to do that yet.
Yeah, and I think that maybe even some of those medications might be for people that don't qualify for bariatric surgery. As you said, maybe they only have 10, 20, 30 pounds to lose. They're not in the morbidly obese category or the parameters that you've discussed here today. But it's always good to talk to your provider and get this information clearly. Now, Dr. Sipe, what is it like for the patients? What is it like after surgery? Lifestyle management, supplementation, going out to restaurants. What is life like as you've seen it for your patients?
Yeah, it definitely changes it. So, what we hear back when patients come in, and really the first month is the recovery process for most patients. Once they're past that, it's into maintenance as far as what they're able to take in and amounts and those things. So say when they go out to eat, what they find is many patients actually ask if we can give them a medical card so that when they go somewhere, they can either order off the kiddie menu or at least have reduced portions to have to pay for, because if they get a regular size portion, they will not be able to complete the meal and will have leftovers for days. So if they're able to do that, great. But oftentimes, again, they just are able to take less, and that's the thing they grow accustomed to. It does take some time, and I'll tell you that patients vary a lot as to how quickly they adapt to how limited of intake they can achieve. It's initially sometimes pretty surprising to them that, man, it's just feels like a fraction of what they normally were used to, and they're full. And that sensation of fullness also changes. And so that's a learning process for most patients. It takes maybe 3 to 6 months to kind of adjust and really see what that looks like. With bariatric surgery patients, we keep them, and our studies really have shown that we need to keep them in close follow up to keep them accountable, keep watching that they're not developing any problems or symptoms related to the surgery. And so for patients after that, we follow them up pretty closely the first 6 months, and then we start to stretch that out. But for most programs, we like to follow those patients out to 5 years to be sure that they've remained successful and kept the weight off.
This is really such an interesting topic and an exciting time in your field, really helping so many people increase their quality of life. And that is so important. And indeed, even possibly the length of their life. And certainly all the pain and the comorbid conditions that go along with obesity. Dr. Sipe, I'd like you to summarize for us, giving your best advice for people who are severely overweight, what you want them to think about. What are you telling them to think about when they're considering bariatric surgery and including their family in these decisions and those support groups?
Yeah, you bet. So, in general, when we talk about that with a patient, it's what areas of your life are impacted by your weight. And for most people, it involves every aspect of their life. And so it's not only that they have these other illnesses that consume their time, consume their money, and really limit their lives, but it's also their life is limited from an activity perspective because of the weight, whether that's the relationship with their spouse, the relationship with their kids or grandkids. They just can't do the things they want to do, or even maybe were used to being able to do before. And so when they look at those things in life, we try to tell them that's how things are restricted. And post operatively, if we can get the weight off, those are the things that will come back. Not only, like you said, will we prolong their lives potentially, but we will improve the quality of the remainder of their life so that they can be more active, they'll have fewer illnesses to worry about, and as a result, have more fulfilling lives.
Agreed completely. Thank you so much, Dr. Seip, for joining us today and sharing your incredible expertise and giving us so much to think about for people that are considering bariatric surgery and the ones that we love. So thank you again for joining us. And I'd like to thank our Bryan Foundation partner, Union Bank and Trust. To listen to more podcasts from our experts, you can always go to bryanhealth.org/podcasts. That concludes this episode of Bryan Health Podcast. Please always remember to subscribe, rate, and review Bryan Health Podcast on Apple Podcasts, Spotify, iHeart, and Pandora. Until next time, I'm Melanie Cole.